All right. I think we can go ahead and get started. That way we can have plenty of time for questions and discussion. We'll briefly introduce ourselves. We've also got microphones as well. I'm Mike Ward. I'm from the Nashville VA in Vanderbilt, and the research director at Vanderbilt as well. Was also the co-chair of the State of the Art Conference that will talk about the research priorities for VA HSR&D for emergency care. Anita, do you want to go ahead and go next?
Hey everyone, my name is Anita Vashi. I'm an emergency medicine physician and an investigator at the VA Palo Alto. I've been in the VA for about 10 years, and my research mostly focuses on veteran access to care in and outside the VA. Nice to see you all.
Good afternoon, everyone. My name is Neil Patel. I have the pleasure of serving as the Acting Executive Director for Emergency Care for the VA, stationed in Los Angeles, and work for a gentleman named Chad Kessler, who was instrumental, along with Mike Ward and Nita, for kind of putting this session together and kind of putting VA EM research on the map. So glad to be here.
All right, thank you. Well, plenty of time for questions. Also want to put in a quick plug for the session tomorrow morning at 8 o'clock. So we get the late session, the early session, but it'll be about how to submit research to the VA that I think is meant to be kind of a primer to learn how to be able to do that, some of the nuances between VA and non-VA settings. So nothing to disclose from our end, so our learning objectives. We want to learn how VA emergency care, health services, research development are organized, how the new HSR&D priorities were developed, and what these priorities are for the geriatric, mental health, and non-VA populations, and then what some of those funding priorities are. So I'm going to turn it over to Neil to discuss more about the rationale for the State of the Art Conference. And there are lots of acronyms, so if there's something that you don't understand, just let us know. When we do have questions, we'll make sure we want to use the microphones since this is being recorded.
All right. Thank you, Mike. I think everyone can hear me. So, the state of emergency medicine in the VA is a bit unique. I would say, I personally started the VA in 2009, and even when I started, I would say it was 20 to 30 years behind what the community emergency medicine scene was. And so, over the past 10 to 15 years, work has been diligently done to establish kind of the clinical standard of care to what the community provides. But what the big part that's missing is that, doing this, we recognize that veterans emergency care is a bit unique. It's not the same. There's different needs, and we'll kind of go into how some of those needs are different, but as you can imagine, geriatric emergency care is a huge priority for the VA. Almost half our patients are over the age of 65, and the burden of mental health is astronomical in the veteran population. Not only primary mental health concerns are present to the ED, but the interplay of mental health conditions in other complex disease processes as well. And so what we recognized was that there's really a need to understand these processes and these kind of these episodes of care better. And luckily, as lots of people in this room know, VA has a robust research infrastructure. It just hasn't shown its spotlight at emergency medicine until now. And so, again, through strong collaboration, we were able to kind of get focus on some high priority areas for emergency care for veterans. And so that's what the State of the Art Conference was. And again, to kind of give a bit of background as to where we were. So if you look at kind of things that would mark our maturity of our specialty in the VA, you can see even in 2007, only 16% of our 1,000 plus physicians were actually EM boarded. That has now improved to we're over the tipping point now at 55%. We just recently did this survey at the end of 2022. But again, huge opportunity there as well. And again, when we look at facilities, when you say EM service, that's VA lingo for independent department status. 10%, right, in 2007. And now we're at this point where a third of our EDs are independent services. When we look at actually the major cities, again, we have a lot of rural sites. When you look at our major city programs, again, half of them are independent service lines. So again, lots of opportunity, but lots of progress as well. And so this, kind of focusing on research priorities is part and parcel of our growth towards maturation as a specialty. Let me kind of point to the next slide, just obviously geographical map to show where the locations of VA medical centers are. So again, our system is comprised of 110 emergency departments, and now it says 29, we just got 2 more, 31 urgent care centers. And VA urgent cares are not like your CVS Minute clinics. They are, they are almost like mini EDs that just happen not to operate 24/7. And so again, lots of data. VA is very data rich for years. And we have a complex network of sites. So again, ripe for investigation. It's really untapped potential that we haven't really kind of investigated yet. When we look at kind of what emergency medicine in the VA looks like, it's really 3 million veteran visits, right? So this is a substantial number of visits if you compare to the overall U.S. population that happen within the VA, right? And so again, there's 3 million visits that happen across for veterans using emergency care. There's 9 million veterans eligible for care, 3 million visits to EDs and urgent cares, again, across the U.S. 2 million of those visits, about 2 to 2.5 million of those occur within VA EDs and urgent care. So you can see veterans strongly prefer to receive their care within the VA system. But even with that preference, when we look at let me back up. In 2018, Congress passed and the President signed legislation called the Mission Act, which allowed veterans a choice as to where to receive their care. One of the items of choice was, where they can receive their urgent care and emergency care. Since that time, when we look at veterans and how much, when veterans go out to the community, how much VA spends, by far and away, the number one spend for community care, out-of-network spending for VA, is in emergency care. And again, you might not think that the emergency visit's really kind of that expensive, and it's not. It's really the emergency visit and the hospitalization that follows that visit. And to those of us who are clinicians, we can easily understand 80-year-old veteran with end-stage renal disease, COPD, CHF, walks into a community ED without their medication record, without their problem list. That person's getting admitted, right? Like there'll be a reason found to admit that person. And so versus in the VA, we can care coordinate. We can say, hey, look, you have a little bit of a CHF exacerbation. Here's some more Lasix. We have a follow-up appointment with cardiology for you next week. All right, and so we have opportunity here. And so part of this is understanding, our research priorities are really understanding not only what drives veterans to community care, but what we can do better to serve those veterans when they are in community care settings. So again, maybe I'll pass it back on to Mike, but you can see this is to set up some of the framing of what set our research agenda. So with that, I'll pass it back to you, Mike. All right.
Step is dangerous up here. So given that from the standpoint of the geriatric population, combined with the fact that veterans are much more likely to die by suicide compared to the general population, given their combat experience, and then the cost of non-VA emergency care, we ended up focusing on these 3 populations as part of our state-of-the-art conference. And if you think about it, from the standpoint of something like the Academic Emergency Medicine Consensus Conference, those are typically very focused questions. So how do you, from the standpoint of the VA, say, what are we going to focus on for all of emergency care? And so this way we were able to prioritize within these 3 groups, not only those populations that commonly present, but those that we can actually do something for. I mean, pediatrics, trauma, that's not really the focus of the VA. This allows us to be able to concentrate our efforts. So what do we do as part of this conference? So I thought it was appropriately named the SAVE conference, right? Like that kind of works out well. That was not mine. That was, I think, Dave Atkins. But this took an extensive amount of time. This is kind of like an AEM consensus conference to a much larger scale within the entire VA. So we started this in October 2020 between planning, identifying who was going to lead this, the work group leaders, who were the participants and the experts that were going to be part of this, then all the way through 2022 conducting these virtual conferences, and then going back, listening to what was said in the first one, and then coming back and revising that for the second part of the conference. And then we finally put together the work group reports in the spring of 2022. And then as you saw, or hopefully saw, in this past month, the special issue in academic emergency medicine just came out. So we had participants for the state-of-the-art conference from across the entire VA and non-VA as well. So myself and Dawn Bravado were the co-chairs of this. But then we also had quality experts, both within the VA and not, so Steve Ash, Christian Helfrich, Keith Coker, also within the appropriately named National Emergency Medicine Office, or NEMO. So Chad, Neil, and then also a researcher in residence, Erica Abel. Also from CIDR, I'm trying to remember what CIDR stands for. So many acronyms. Center for Implementation Dissemination, yeah. Even gets the acronyms for all of us. So HSR&D as well. There's also something called the Evidence Synthesis Program, which I'll talk a little bit more about. And then we had our group leads in geriatrics, so Yilu Wang, Nikki Hastings, mental health, Jason Chen, Chris Timko, and then community care, Anita Vashi and Chris Maddox. So within each work group, we had about 15 to 20 participants, including VA and non-VA clinicians, researchers, and operational partners. And these were also interprofessional. The VA, as many of you know, is very interested in interprofessional collaborations, so not just physician-driven. Each work group was given 2 priorities, and we're going to focus on the research aspect of this. But there were 2 questions. So what important questions do not have sufficient evidence to guide practice and clinical policy? Those became our research recommendations. Versus where's evidence sufficient to move to implementation? That became more of a policy recommendation. The policy recommendations are within the special issue in that paper. So I'm not going to go into those here, but we'll focus primarily on the research recommendations. So I did not lead the geriatric or the mental health group, but I will present their findings. But fortunately, we have many of our geriatric colleagues here who participate in those work groups. So don't be afraid if I call on you, and I apologize in advance. I'm just kidding, I'm not going to call on you. But there were some conflicts, so they weren't able to attend. So we'll start with geriatrics. Here are the participants in this particular group. Again, broad array of VA investigators along with non-VA investigators as well. I think from the rationale, we've kind of drilled that home a little bit, that a large proportion of our population are geriatric veterans. They have a higher medical burden, often other cognitive and social challenges that go along with the emergency care that they receive. And then the VA really has tremendous resources for this patient population between both the geriatric and extended care support programs that exist and the geriatric ED initiatives. So to start each of these groups, we had an evidence synthesis program that allowed us to be able to look at what evidence was already there. And so the evidence synthesis program is a wonderful program that the VA offers to be able to, in this particular case, conduct an evidence inventory. All of these are available in the special issue in the appendices. So typically, many of these ESPs may not be actually available until they're publicly available or they're behind the VA firewall. We were able to get these released, and for the first 2 months of the special issue, it's open access. So you should absolutely be able to get access to these. And so the 2 that they did for the geriatric group were the geriatric risk assessment tools and then telehealth interventions for older adults. So there were 5 priorities consistent with Corey Slovis from Vanderbilt, where I'm at, that we'll talk about. The first was around variations in care and its impact on outcomes. So this was focusing on how care processes vary across geriatric EDs and VA emergency departments. Which care processes, sorry, I'm having difficulty with that, and other sources of variation that occur across these, and how do processes impact care partners and the staff. Priority 2 was strategies to improve the quality of emergency department discharges. So looking at those care transition plans and then longitudinal care as patients go from the ED to the community. and then testing novel approaches to improve the quality of those care transitions. Priority 3 focused on telehealth. In this population, how can it be used to support acute care in nursing homes? For example, prevention of transfer of a veteran from a nursing home to the ED. What contextual factors can influence the success of telehealth? And what use cases are safe and most effective in telehealth for the older population? The geriatric ED initiatives, which many of you are already familiar with. How has this geriatric ED accreditation impacted patient outcomes, use, and costs? And what's the impact on patient care partners and ED staff for the implementation of these processes across VA EDs? Finally, improving implementation of geriatric risk assessment tools in the emergency department. How can we best identify those gaps in those who are at risk? How can we leverage existing risk scores that are available and unique to the VA? Who should we assess? Which tools should we use? How should the ED use social influencers of health to best integrate it into workflow? And whether we keep those veterans in-house or do this as an outpatient workup? And then what are the best practices for inclusion of our care partners in risk assessment? So that's the geriatric priorities. The next is going to be around mental health, and then we'll transition to our community care. So for mental health, again, Jason Chen and Chris Timko led these two groups. Some context in these populations. Mental health visits are a common reason for veterans to present to the emergency department. Some work that our group showed that mental health reasons are the most common for interfacility transfer from VA emergency departments. And then mental health visits are also one of the most common reasons for potentially avoidable transfers. And it's really a key source of intervention, especially in patients who are in crisis. And then COVID-19, whether you're in the VA or not, really increased the demand for emergency mental health care. There are also a number of national initiatives from the VA Office of Mental Health and Suicide Prevention, including Risk ID, SPED, and Advanced Safety Planning Training. So again, we started with an ESP, and this was called Effectiveness of Mental Health Interventions in the Emergency Department, also available in the special issue. And there were three key areas that we focus on: suicide, substance use disorder, and then treatment of psychosis. So from the suicide standpoint, what we found in the ESP was that most randomized trials showed a positive treatment effect on recurrence of suicide attempt, and that when you think about the interventions that coincide with these, the successful implementation strategies involved clinicians having sufficient time, right, consideration of that workflow, that there were screening protocols or interventions that were integrated into the ED workflow to make it easier to be able to do and coincided with what was already being done, and that the clinician or the provider had rapport with the veterans who they were caring for, and then the collaboration of their colleagues. Substance use disorder, not surprisingly, focused on primarily opioids, despite the number of other potential conditions, but was really limited by the number of available randomized controlled trials. And then for treatment of acute psychosis, there are really no primary studies on acute psychosis focused ED interventions. So there were three priorities that this group identified. The first was around enhancing the reach of effective suicide interventions. The question is, though, which modalities are really best at being able to do this, and how can we enhance care as a result of this? What are the components of these interventions, right? A lot of times we do the kitchen sink. We throw everything at them that we can, but what's really most important from this? Telephone contact by mental health, screening, safety planning, care management. Then how do socio-demographic characteristics and the features of these interventions impact the effectiveness? And which models of care delivery? So we have different models of emergency care for mental health. There's one that has a dedicated psych emergency department, but then we also have some in which there may be access to emergency physicians who then subsequently consult with psychiatry, all the way up to emergency psychiatrists see every veteran. Priority 2, develop rigorous evaluations of interventions to manage substance use disorders. So what are the key outcomes that really matter in these for both opioid and non-opioid use disorder? Which components of these interventions should be used? And which personnel should also deliver these? Does it always need to be done by a physician, or can also peer specialists be a component of that? And then finally, identifying and examining safe and effective practices to manage acute psychosis. There are some groups that are training emergency physicians with specific programs around management of acute psychosis. How effective are those? How well are they implemented and taken up? Do psychosis guidelines enhance patient and staff clinician safety? And what's the adoption of these? So I'm going to go ahead and transition it over to Dr. Vashi, who's going to talk about community emergency department care.
Okay, so similar to the other work groups, our community ED work group, which was led by myself and Dr. Kristen Maddox, had a wide range of individuals both in and outside the VA. And I think Neil provided a really great background for this topic area, and I assume most folks here are pretty familiar with VA and VA lingo, but just to provide a little bit more context, there's 110 VA EDs, as Neil said, and obviously not all veterans can access that in a timely way when acute unscheduled needs arise. So there have been mechanisms in which VA will pay for care in non-VA settings going all the way back to like the 1950s and even earlier. A lot of those programs and policies were kind of complex and confusing. And so as a result, we've had new legislation, Choice, Mission Act, which has made the way that emergency care in the community paid for, how we get notified about it, and the reimbursement rates have both become simplified and the reimbursement rates have gone up. So with the goal of making it easier for veterans to access care when they need it, where they need it, which is great, but it is also slightly problematic for VA in that it has now exploded. We have a lot of care in the community that VA is responsible for paying for, and as Neil said, it is like the #1 most costliest reason for care, and that's raised a lot of attention beyond just our EM community all the way up to the Undersecretary of Health for VA. And so that's obviously a reason of focus for the SOTA conference, and we narrowed our research priorities down to 3 with a lot of sub-bullets. And the first one is really better understand how the expansion of access to emergency care in the community has impacted ED utilization, access, and costs, with a particular interest in causal inferences where we can really get insights into the mechanism of these changes and particularly modifiable factors, those things that we can do something with. So, how has expansion associated with change of use in VA, EDs, and urgent cares? What factors influence veterans' choice of acute care settings? Is the increase in non-VA care associated with a relative decrease? So is it a substitute or a complement to VA care? How has the case mix or acuity changed? How has the expansion of non-VA ED care impacted total VA expenditures, especially for comparable episodes of care? So example, CHF in the community versus CHF in the VA. How, are there differences in cost, quality, outcomes? And then also, as we saw in COVID, a rapid explosion in virtual care. So how do VA and non-VA virtual care options impact the use and cost of non-VA ED use? Our second area of focus was primarily around care coordination and really trying to understand the follow-up needs of veterans who have received care in the community. Are their care coordination needs different? Are they different for different populations? What information do VA, non-VA providers, and veterans need to ensure safe care transitions? How do we transmit that information across these different care setting types? We're also interested in understanding, how does the use of non-VA acute care affect subsequent frequency of VA PCP, specialty care encounters, reliance on VA? Do they stay attached to the VA if they end up in the community, or do we kind of lose veterans to community care after they have these ED visits on the outside? Also, again, with virtual care, how does availability of virtual care options impact provider and veteran decision-making or facilitate veterans receiving timely follow-up care? What are some of the barriers and facilitators to veterans receiving timely follow-up care after an ED visit in the VA? Our third area was really about the kind of veteran experiences, quality, and safety. So kind of comparing those dimensions between VA and community emergency care. So how does veteran experiences and satisfaction differ across these setting types for different types of care needs? How do VA and non-VA ED care compare on both established quality and safety measures at both patient and ED levels? And I know we're not getting too much into the policy implications, but I will, since we have a slide here, I'll mention a little bit about it. As we mentioned, community care costs are the number one cost. So this kind of opened everyone's eyes in VAs to this issue. And so they, at the VA central office, organized something called Co-ED, which is care optimization in the emergency department. And it brought together a lot of operational stakeholders to try to figure out, what are we going to do about this problem? Everyone, wants to make sure that veterans get the right care at the right time, the right place. But are there things that we can do to kind of keep care in VA when that makes sense? And so they're exploring all types of options, including things like more expanded care coordination for frequent utilizers, figuring out who are your, top 100 frequent utilizers in the community. Can we do some more intensive case management with them? Can we become more like a Kaiser and repatriate patients back to the VA from the ED? Exploring all these options. And so one of our recommendations was that if these solutions are going to be implemented, we really recommended rigorous program evaluation to understand what works, what doesn't work, and why. And when possible, trying to do some randomization so we can really understand the true impact of some of these programs. We also identified some barriers to this work. We wanted to put that out there, so hopefully just drawing attention to it, maybe we could work to kind of resolving some of these issues. I think the biggest thing, one that we kind of mentioned over and over again, was just the need for better data. So the VA, we know the care that we provide in the VA, we know the care that we pay for in the community, but that's a small percentage of care that veterans are getting in the community. Veterans have Medicare, they have private insurance from their jobs, and so there are a lot of other ways our care is getting paid for that we have very limited insight to. It may only be 30% of all ED visits are at VA or paid for by VA. So without understanding that other kind of care, it's hard to sort of understand the true needs of this population. So a lot in here about timely data, being able to link to other data sets. There's a lot, especially for a lot of our questions are about, how have policy changes impacted use when we've also had COVID, which we know has had impacts on ED utilization more generally. So, how do we kind of account for that when doing some of these analysis? We also have to account that there's a changing veteran population and demographic, understanding the role of veteran choice. In some of our work, we found that, it's not always that the veteran decides where they're going to go. It's their doctor told them, go to your closest ED, or oftentimes the paramedics, they don't even leave it up to the veteran to decide where to go. They kind of determine where they think the best place for them is. So we definitely want to try to expand the perspectives that we bring into some of this work. So those are sort of the priorities by the three different groups that Mike and I covered. And then we also kind of realized that there were a lot of cross-cutting themes among these three groups. And so the first was that there's a need for team and system science to enhance workforce development into a lot of this work. Two, a need for implementation science methods to develop and test some of these interventions. And then I think post-ED follow-up and care coordination was a theme throughout. And the virtual care component was another big cross-cutting theme through all three groups. The other need that we identified after our SOTA was that there is a need to develop the capacity of EM research in VA. And so we spent a lot of time thinking about how to do that, how to build a pipeline of VA EM investigators, whether it's mentoring junior faculty, encouraging them to enter VA fellowships, CDAs, kind of developing closer relationships with our academic affiliates, so encouraging non-EM investigators to submit VA EM proposals, joining our existing network of VA EM investigators. Most of us are like the only person at our center doing research related to EM, so Mike created this great community where we meet virtually twice a month. If you want to join, please contact Mike, where we get to workshop our ideas in a very casual setting. So it's a really nice place to start if you're curious about VA research or VA emergency medicine research. We'd love to have you. And then just trying to find ways to continue developing the data and the infrastructure for that. So as far as next steps, as Mike discussed, we had this great opportunity to have a special issue, and so that came out, and so you can see a lot of great work by VA researchers. I was really impressed by the breadth of work done by people all throughout the VA, both in emergency medicine, outside of emergency medicine. It was really exciting to see. And the other nice thing is that because we developed, HSR&D, which is our funding agency in VA, they, invested in this SOTA, so they are invested in our outcomes. And I don't know if all of you are aware, but every year, HSR&D releases about 5 to 10 priority areas. It typically includes things like access, mental health, and this year, emergency medicine is one of those priority areas, and that's huge. So, if you're interested in VA research, this is the perfect time, right? It's a priority area for VA, and we've literally laid out a blueprint of questions that you could choose to answer. So it's a great time to be a researcher in VA. And I think I'll end there. We have a lot of people to thank for this effort. And I think at this point, we can just open it up to questions.
And I'll say too, just kind of building on that as well, that, as someone, so I chair one of the VA study sections in HSR&D, and when we talk about the idea of significance, it's not like, hey, this is an important area of investigation, but rather, no, this is a specific priority, the SOTA identified this, it gives you basically extra points, and it's not just lip service. So it also helps focus when you're thinking about, because emergency medicine can obviously be a broad area. Even geriatric emergency care can be a broad area within this. And so being able to focus this and then say, here's the reference around which it's a priority is really nice. And the whole goal here is help facilitate emergency care research. So we wanted to be able to have enough time for questions. So we can just come around if there's a question, and then we were told that we should use the mic so I can walk around if needed. But what questions you all have, we can have a discussion just in general about VA emergency care. And then if you go ahead and say your name and where you're from.
So Jin Han from Vanderbilt University, Vanderbilt. So we've been, regarding the last priority in terms of the Mission Act and how veterans are using outside care, I guess, where does the CCC, the Clinical Contact Center and telemedicine, fall into all this in terms of priorities? Because I think I'm seeing more and more use of the Clinical Contact Center, and also, assessing the quality of those those interactions as well. Because I don't know how many times where, I have a patient, they call and they go to the ED. I'm like, why are you here? Because they told me to come here.
Great question, and I totally feel you. So for context, the clinical contact centers, so VA has had clinical contact centers dating back many, many years. The primary function of that was to have RN triage. So a patient calls in, I have chest pain, they work through an algorithm, and then the nurse spits out a recommendation, go to ER now, go to ER 2 to 8 hours, see your primary care doctor tomorrow. There's a range of options, right? But especially during COVID, there was a push towards modernizing these clinical contact centers. So there's a program now called VA Health Connect. That's the official name. And the idea is to have a one-stop shop for veterans. They call this 1-800 number, and they get offered 4 service areas: administration and scheduling, pharmacy, they are in triage still, and now they're going to offer virtual urgent care. And as, I don't know, call it a supplement to VA Health Connect, or in conjunction with VA Health Connect, there is VA tele-emergency care, which is kind of run out of the EM program office, and that is, I don't want to get too into the weeds, but basically it's another way to provide virtual care to veterans when they call into this contact and center, which is wonderful. But one thing that we found is that I think it's only about 3%. So if you look at all the ED visits, only about 3% of veterans are calling in to the clinical contact centers in the 48 hours before an ED visit. So its reach is quite limited at this point. And I think that's one area where the VA struggles in. There's so many like innovative, interesting programs and policies, but it's really hard to reach the veterans. And I think there's a lot of work that could be done in that space about like promoting and outreach and education. And I agree. I think, how they decide to sort of staff these clinical contact centers will matter, because sometimes, veterans are getting very frustrated when they're like, I came here because the doctor told me to on the phone, and, I discharged them in 10 minutes or whatever. And so I think what we're, interested in seeing is if we staff these with emergency medicine physicians, is there a difference? And that's something that we could start studying as tele-emergency care in VA starts to grow. So does that kind of answer your question?
Is it a priority? Does that fall into the priorities of HSR&D?
Yeah, so I will say that it's a huge investment for VA, like hundreds of millions of dollars, mostly because this kind of blew my mind. Just like they had to switch over the telephones and the systems to like do this type of care at every single VA, in the country. So it's a lot of infrastructure investment. So yeah, it's a huge priority area for our program office. The program office being IVC, which is Integrated Veterans Care. And so my team got funding to evaluate VA Health Connect. So that's one of the things that we're doing now is to see, does calling into the clinical contact centers end up in a reduction in ED visits or not. So that's the nice thing about VA is not all funding has to come from HSR&D. Program offices will also fund things. We're also now getting query support to do that evaluation. And I imagine that there are like 100 questions you could ask about clinical contact centers. So I'm sure people could apply for funding to ask, other questions that they might have. So I would say yes.
And also, going back to the cross-cutting themes as well. That absolutely fits. And I think we somewhat kept it broad enough as well. You can get most questions that you're really interested in. It's all a grantsmanship issue anyway. But with a good argument, for most things, you can frame it as a priority. But telehealth very clearly is. And the clinical contact centers, I think, fit really nicely in that.
Just to add, the tele-emergency care aspect of it is that not only an HSR&D priority, but it's a program office, like in my office. That's a huge priority area for us. And even taking that sub-bullet point of tele-emergency care, there's like a million questions that we have about it. Because again, this is not a program that exists outside at scale in any healthcare system. Kaiser is probably the one that comes closest to it, and they have a different model. So we don't know what types of chief complaints are most amenable to successful resolution through tele-emergency care, what types of chief complaints we should not handle from the get-go and just not delay their care. There's an equity piece here that, we're not studying either. Is this equitable distribution, or is it just people who have resources to have an iPhone that happens to have a camera? So there's like a million questions that we have just around tele-emergency care alone. And, again, bright barrier for investigation. We're trying to build in, again, programmatic support for post-implementation analysis of these programs. So huge opportunity area in just that space alone, let alone our other priorities of geriatric emergency care and kind of what interventions work there, what interventions don't work, what screenings are most valuable to conduct. And that will really help us streamline and honestly standardize approach, because we have now an evidentiary basis for those programmatic or policy decisions.
The other thing that I think is really important from the standpoint of submitting research to the VA, and we'll talk about this tomorrow morning as well, is the importance of operational engagement. We're starting to see this more in non-VA research, NIH, in thinking about the implementation of this. But this is something that's heavily prioritized in the VA. I mean, what better operational engagement do you have than the National Director from Emergency Care being here? But then the other key, too, is the letter that, well, you write for him. But it's the specificity of it and how important it really is to his office. And having that shared partnership between research and operations is tremendously important to the VA and HSR&D. They want us to list this.
Hi, I'm Mackenzie Orr. I'm an NCSP fellow at the West LA VA. I had a question about if we were interested in looking into doing research on one of the research questions that's outlined in one of the priorities, and it's kind of tangential to the work that we're doing already. What's the best way to plug into the people that are exploring that already and kind of build on the work that they're doing?
Come to our Thursday research meetings. And we can definitely put you in contact with whoever's doing work in the space. It's a small enough community that I think we really know everyone and know the right folks to talk to. And as a fellow, I think there's a lot of fellows and former fellows in the room that I think have gotten good projects and things in similar ways. So you're definitely welcome to join us.
I certainly think that within the VA, one of the most important things is sort of institutional knowledge and who you know and how they navigate the process and just opening those doors. Certainly outside the VA is important, but especially in the VA is important. And so it's for exactly those reasons that we've been doing these, God, for how many years now? I mean, yeah, it's been a long time. But you know, you can vet questions, you can talk about how to problem solve, you know, how'd you handle it yours? You know, and certainly I know I'm going to tap into that for, you know, the next phase of my merit work. So absolutely, Thursday's a great way to be able to do it. We have once a month. I think it's the last Thursday, and I can get you my information. We can get you on the list. Oh, perfect. There you go. No, it's once a month. Yeah, we switch it just to, you know, it's tough when everybody has so many meetings, and we want to be able to make sure that we concentrate it and that we get a good use out of it. But, you know, talk about your aims, how to structure, you know, how you're going to submit something, potential collaborations, opportunities that come up, you name it. It's basically like a work in process meeting or a lab meeting. What other questions do you guys have? All right. Well, thank you all for coming. Please take a look at the special issue of Academic Emergency Medicine. Share it with your friends. It's open access for 2 months. I highly recommend looking at the article that Neil and Chad wrote as well around the hidden jewel of emergency care. It's a great piece to share with someone who's thinking about emergency care in the VA. It really captures the sentiment tremendously for what it's like to be able to work for and care for veterans, which I think is tremendous. So thank you all for coming.